So, starting by the two. What are the learning objectives for today? I'll introduce dementia, give an epidemiology, maybe brief radiological anatomy, classifications of the common subtypes, role of imaging, some challenges that are encountered in dementia imaging, a conclusion. By way of introduction, dementia is basically a disorder that is characterized by progressive loss of selectively vulnerable population of neurons via physiologic processes, which will include proteolytic and oxidative phosphorylative stress, neuroinflammation, and apoptosis, which will be leading to neuronal dysfunction and death. And it's also important to state here that normal brain aging and neurodegenerative diseases form a continuum. Neuroimaging was primarily used to exclude treatable causes of cognitive impairment, such as subdural hematomas and tumors. Okay, subdural hematomas and tumors. Now, definitive diagnostic test is brain biopsy or postmortem neuropathological analysis, but neuroimaging has made it possible for us to an extent, and a very high extent for that matter, be able to diagnose dementia, profile dementia into the various subtypes, and also prognosticate in terms of searching out ways for novel therapies. Okay, sorry. Now, dementia is a syndrome that is due to progressive impairment in at least two of the following 6 cognitive domains: complex attention, executive function, such as the ability to plan and carry out a program or event, learning and memory, language, perceptual, motor or visuospatial function, as well as social cognition. And according to the Diagnostic and Statistical Manual 5 edition 2013, it must be severe enough to interfere with independent daily functioning. Dementia can occur in young people, and it's primarily a disease of the elderly. The patients are greater than 65 years, and is a female predilection. Some studies have postulated that in 2040, which is about 16 years from now, we would have 81 million people living with clinically and radiologically diagnosed dementia. In 1992 in Ibadan, southwest Nigeria, Oguni et al. Identified no cases of dementia. However, in the same location in 2006, they found out a prevalence of dementia to be 10.1%. In 2019, Adeloye et al. Revealed the overall prevalence of dementia in Nigeria to be 5%. In 2022, Rufus et al. Saw African burden of dementia to be between 22.3 to 20%. And in profiling the dementia subtypes, Alzheimer's disease, vascular dementia, and HIV/AIDS neurocognitive disorders were the prevalent subtypes. Now, globally, between 1999 and 2016, the incidence of dementia has increased by 117%, according to a study by Ima Nicole et al. Now, this is just a map of Africa where we've seen relative study being carried out about dementia prevalence. The host country, I don't know if you can see my, okay, sorry, Mr. Shola, can you see my cursor? Okay. So the host country, Nigeria, has incidence and genetic studies being carried out, and as well as familial cases and an organization on Dementia and Care. This map here just shows the statistical prevalence of dementia, and it's just telling us that dementia is within 5% as earlier studied by Adeloye in 2019. Now, radiological anatomy of the limbic system, which is the cortex implicated in dementia, is not limited to the amygdala, the hippocampus, the entorhinal cortex, basal ganglia, the fornix, which connects the hypothalamus to the hippocampus, spinal cerebellar tract, and spinal motor neurons. Now, this is just an image, a gross image that is showing the medial aspect of the brain. Now, we can appreciate the entorhinal cortex that is labeled here, as well as the hippocampus. Now, the hippocampus is a gray matter and is seen as a curved elevation in the floor of the temporal horn of the lateral ventricle. On a coronal section, it is seen as a seahorse. It gives a seahorse appearance. Now, it has a head, body, and tail via the cornu ammonis 1 to 4 that is covered by a thin sheet of the alveolus. I don't know if you can see my cursor. Can you see my cursor?
Yes, we can. Yes, we can.
Okay, so yeah, thank you very much. So this is the hippocampus rather. Sorry, the hippocampus. So you see C4, C3, C2, and C1 is being covered by a thin sheet of white matter, the alveolus, that continues medially as a fimbriae. The dentate gyrus is connected to the head of the hippocampus, and the hippocampus continues as the subiculum that continues also as the parahippocampal gyrus, and this depression here, the collateral sulcus. Now, the hippocampus regulates behavioral patterns, emotion, and memory. So the image on my left is a gross image, a coned down gross image of the medial temporal lobe that is showing the hippocampus. Now we can appreciate the dentate gyrus here, the C4, C3, C2, and C1 segments of the hippocampus that continues as the subiculum, the parahippocampal gyrus, and the depression here, the collateral sulcus. Now, the choroid fissure is just a space in the system, in the brain rather, that is medial, that lies medial to the hippocampus, while the temporal horn lies lateral to the hippocampus. So the image here is a T2 weighted coronal magnetic resonance image of the brain taken at the level of the lateral ventricle. The arrow pointing blue here actually points to the hippocampus. The arrow yellow here points to the collateral sulcus, while the green arrow points to the parahippocampal gyrus. The red arrow here points to the tentorium cerebelli. Now, dementia can be classified into adult group and the pediatric group. Now, for the adult group, we have tauopathies, which are aggregation of abnormal tau, phosphorylated tau proteins. Examples are Alzheimer's disease, corticobasal degeneration, frontotemporal lobar degeneration. Synucleinopathies are actually accumulation of alpha synucleins or ubiquitin proteins in the neurons in the brain. An example would be, under the subclass, would be dementia with Lewy bodies and multiple systemic atrophy. Beta amyloidosis build up in the brain, which are basically just plaques, beta amyloid plaques, are usually seen in Alzheimer's disease, cerebral amyloid, and angiopathy. Now, transactive DNA binding proteins, 43 proteinopathies. Examples are amyotrophic lateral sclerosis, frontal temporal degeneration or dementia. The prions, example of which is the Creutzfeldt-Jacobs disease. Now, classifying adult dementia based on clinical features will be divided into a cognitive predominant dementia type or a movement predominant dementia type. And under the cognitive predominant, we have Alzheimer's disease, frontotemporal lobar degeneration, and the prions. While for movement predominant, we have Parkinson's disease, motor neuron lesion, ataxia, and chorea. This is just a pie chart that is showing the various distribution and prevalence of dementia subtypes. In less than 65, Alzheimer's disease still tops the chart as the most prevalent dementia type, while in greater than 65, Alzheimer's and vascular dementia are, um, are predominant. Childhood dementia is essentially a neurodegenerative disorder that is seen in a child and is responsible for demise of this child less than 18 years. So they are basically just genetic and biochemical changes that occur as a result of majorly inborn errors of metabolism. So under this classification for childhood dementia, you would have errors within the subcellular organelles, so lysosomal disorders such as mucopolysaccharidosis. MPS1, that's MPS is mucopolysaccharidosis 1, includes the Hurler syndrome, Hunter syndrome, and Sanfilippo syndrome. So there are a myriad and gamut of pediatric dementia examples under this classification. What is the role of imaging? The role of imaging basically is to diagnose dementia. If all subtypes, could it be Alzheimer's? Would it be frontotemporal lobar dementia? Would it be dementia with Lewy bodies? And the likes. It also studies the extent of structural, functional, and metabolic effects of dementia, rules out complications, and it monitors the progress of the disease entity before and during therapy. This is a schema that is an algorithm that just tells us about signal changes that occurs in cognitive impairment. So if there is a vascular component to cognitive impairment, this schema is able to, at least to a very good extent, highlight the possible causes and the location. So signal change assessment, we use FLAIR and T2 hyperintense signals. Now ideally, we shouldn't have a hyperintense signal on FLAIR, but if there is it in addition to a T2 star hypointensity, which could be due to flow artifacts, calcification, or brain microbleeds? Now, if there are brain microbleeds, really, what is the distribution? Lobar distribution, do we have it concentrated in one lobe, which can either be one or more, or do we have it in deep brain regions, such as the basal ganglia? Now, if it is in strict lobar distribution, just in one lobe, frontal, parietal, temporal lobes, we'll be thinking of a cerebral amyloid angiopathy. Now, if they are in deep brain regions, we'll be thinking more of a hypertensive atherosclerotic vasculopathy. Now, FLAIR or T2 hyperintensity, if it's present and is located in the cerebral white matter, now they could just tell you that this is white matter hyperintensity of presumed vascular origin. Now, if it's located deep in the basal ganglia, you'll be thinking of subcortical hyperintensities of presumed vascular origin. Now, if there are multiple confluencing periventricular deep white matter hyperintensities that are affecting at least 25% of the total white matter in the brain, you'll be thinking of vascular cognitive impairment due to small vessel disease. Now, another algorithm was developed to assess cerebral atrophy. So if there's cerebral atrophy and is generalized, it could be due to Alzheimer's disease, dementia with Lewy bodies. It is cerebral atrophy that is focal and is in the frontal lobe. We'll be thinking of the behavioral variant frontotemporal dementia or the corticobasal syndrome. If there is a preference for, because usually for dementia, we don't usually have symmetric cortical atrophy. So they could be symmetric. If you have left more than the right, you'll be thinking of a posterior non-fluent aphasia. If it's focal and it's temporal, left more than right, you'll be thinking of semantic dementia or frontotemporal dementia, the behavioral type. The temporal, if it is right or left, you'll be thinking of behavioral temporal, frontotemporal dementia. If cerebral atrophy is now infratentorial and is including the midbrain, you try to rule out a progressive supranuclear palsy. Then if it is a focal hippocampal atrophy, you'll be thinking of Alzheimer's disease, disease with Lewy bodies, microtubular associated protein dementia, or hippocampal sclerosis, which can be asymmetric, really. Imaging modalities that are used in assessing the dementia includes magnetic resonance imaging, computed tomography, then perfusion studies, the single photon emission computed tomography, positron emission tomography, arterial spin labeling, and the diffusion modality, which will include the diffusion tensor imaging. Now, it is important to note here that there is no universally accepted or recommended protocol for profiling dementia. So usually what happens is, based on local preference, based on studies that are done locally and the equipment that is available, studies have been able to generate a near normal or acceptable protocol for imaging dementia. Now, first of all, dementia using MRI protocol should be imaged with a 1.5 or 3.0 Tesla machine. T1 weighted images are obtained. An example would be a magnetization prepared rapid gradient echo images, which are 1 mm isotropic voxels. They are used in the assessment of medial temporal atrophy. Now, FLAIR images, axial 3 mm slices, 1 mm isotropic voxels are used to assess global cortical atrophy, vascular white matter and hyperintensities, as well as infarct. T2 weighted axial 3 mm slice thickness, 1 mm isotropic voxels, fast spin echo are used to assess lacunar infarcts in the thalamus and basal ganglia, because on FLAIR, you can actually miss out on lacunar infarct in the thalamus due to flow artifact. Now, T2 star, example of which is a susceptibility weighted imaging, you have 3 mm GRE slices, a small flip angle. Now, flip angle usually used in MRI are between 0 and 90. Now, for dementia, studies and some authorities have recommended the use of a small flip angle as little as 19 to 20 something degrees. Now, T2 star helps you to evaluate microbleeds, which can be seen in, if it's a lobar distribution in cerebral amyloid angiopathy, or in deeper brain regions such as the thalamus and the basal ganglia, to rule out hypertensive arteriopathies. Now, there could be mineral deposition in the cortex in Alzheimer's disease, or loss of signal intensity, as we would see in substantia nigra, which is typical for Parkinson's disease. Now, diffusion weighted image and its afferent diffusion coefficient map. Isometric images from optional diffusion tensor acquisition are produced or are generated to assess cortical and deep white matter restriction, which can be seen in Creutzfeldt-Jakob disease or cerebral vasculitis. Now, diffusion tensor imaging deals with the movement of water molecules along axons. So, fractional anisotropy just tells us about the movement of water molecules from the presynaptic areas to the postsynaptic areas, while mean diffusivity just tells us how is this water molecules able to move across synapses. Now, studies have shown that mean diffusivity is reduced in some white matter tracts such as the splenium, the cingulum, and fornix in that order in patients that have dementia. Magnetic resonance perfusion is also an interesting area in neuroimaging where because the ideal thing is that perfusion and metabolism should occur concurrently. So wherever blood goes, metabolism should be there. So it also makes sense to for us to explore this aspect of magnetic resonance such that wherever there are no neurons, it's expected that there is no perfusion, it's expected that metabolism is also reduced as well. Then MRI spectroscopy just tells us about the presence and concentration of several metabolites in the brain, such as choline, creatinine, N-acetyl aspartate, myoinositol, and lactate concentrations in the brain. Now, arterial spin labeling as a form of diffusion, perfusion rather, is a non-invasive magnetic resonance biomarker that uses water protons as a diffusible tracer. So now, what these images are just showing, these are a series of T1 sagittal magnetic resonance images. Now, what these images just typify is that there is a pulse that is sent into this is the region of the carotid arteries. So red blood cells have water molecules within them. So the protons within these water molecules in the red blood cells are labeled. Now, when they are labeled, they are given some time for that's using the post labeling delay. And when they arrive in the brain, at the tissue level, where it's expected that there's some perfusion going on and metabolism going on there, you now image or acquire images of the expected areas that you have already magnetized these water molecules or these proton molecules within the red blood cells. Now you now have almost similar control and label images superimposed together. Now, if you, well, due to some processing algorithms, you're able to extract the perfusion weighted images from the control and label image overlap. It now gives you an idea of the perfusion of the brain or perfusion of that region as it were. Now, it is important to note also that changes in cerebral blood flow will occur years before clinical symptoms of neurodegeneration is seen, even in structural volumetric analysis in MRI. Now, when that is done, when you have a perfusion weighted image, you now try to, there are also powerful algorithms and computer processing that helps us to get a cerebral blood flow map. So basically, areas of the brain where there is activity, where there is metabolism will light up in the brain, and when there are no perfusion or metabolism, those areas will show paucity of color flow or color map rather, color map. Now, there are visual scoring systems that are very important in analyzing dementia, and they're not limited to the global cortical atrophy, MTA, and ERICA score, the CODAM score for parietal atrophy, which is also implicated in Alzheimer's disease, Paseka scale for white matter lesions, which is implicated in vascular dementia. Now, these are a series of T1 weighted axial magnetic resonance imaging, or images rather. Now, GCA 0 just shows you that there is no cortical atrophy. So looking at this brain from the frontal, the parietal region, there is no cortical atrophy, just on eyeballing it. But it is deeper than just eyeballing. You also have to do some volumetric and statistical measurements to be able to tell if there is really significant atrophy. Now, for global cortical atrophy 1 or stage 1 or class 1 as it were, you will get to appreciate mild widening of the cerebral sulci. So you can appreciate mild widening here of the cerebral sulci. Now, for GCA2, you can have moderate loss of the cerebral gyri. So you can appreciate on the temporal lobe here that there's moderate loss of the gyri, while in GCA3 there is the end stage atrophy where you have knife blade pattern of cerebral cortical atrophy. The medial temporal atrophy scale is a visual rating that evaluates the width of the choroid fissure, which is this medial hypointense area in this coronal section of the T1 weighted MRI image. Is this medial portion, the hypointense medial portion here. Now you can appreciate that on this on this first image labeled MTA 0, the hippocampus, which is this structure here, this hypointense gray matter here, is still full, as it were. At least the visual is a visual rating, so it's still full. There is no atrophy seen bilaterally, and the truth is you can have asymmetric MTA scores. So you can have an MTA for the right as 1 and the one for the left as 2 or 0, as it were. So a class 1 or a score of 1 for MTA scale just tells you that there's some widening of the choroid fissure, which is the choroid fissure, which is seen here bilaterally. Now, an MTA of 2, in addition to widening of the choroid fissure, there is also widening of the temporal horn of the lateral ventricle, which is seen here. This CSF intensity seen here. An MTA of 3 just talks about the height of the hippocampus. So at this point, we know that there is an established widening of the choroid fissure of the temporal horn. Now the hippocampus rather is now reduced in size. Then for a score of 4, the severe volume loss, where it seems like the hippocampus is sleeping within the temporal horns of the lateral ventricle. Now, for a score of less than 2 is normal for a less than 75-year-old individual. Then above, a score of 3 and above is abnormal for patients that are 75 years and above. Now, the ERICA score just tries to explain that neurodegeneration actually starts in the entorhinal cortex before it now gets all the way to the parahippocampal gyrus and affects the hippocampus. So if there are changes that we should see, volumetric changes that we should start seeing them in the entorhinal cortex. And now this area that is dotted here on this coronal cone down T1 weighted magnetic resonance image of the brain, the dotted image here is the entorhinal cortex. So it involves the parahippocampal gyrus, the collateral sulcus as well. Now, an ERICA score of 1 just shows that there is no atrophy really of the entorhinal cortex. There is no atrophy here. Now, an ERICA score of 1 just tells you that there is some atrophy that is evidenced by widening of the collateral sulcus. So this widening of the collateral sulcus that is not seen on ERICA 0, really. So widening of the collateral sulcus has a score of an ERICA score of 1. An ERICA score of 2 just shows you that there is detachment of the entorhinal cortex. This is the whole of the entorhinal cortex from the tentorium cerebelli, giving this tentorium cleft sign. The tentorium cleft sign is seen by visually separating the tentorium from the entorhinal cortex. So basically, entorhinal cortex just shows you this CSF intensity strip between the tentorium cerebelli and the entorhinal cortex. Then ERICA score of 3 is severe atrophy of the parahippocampal gyrus. So this is what is left of the parahippocampal gyrus, what is left of it bilaterally. Faseca score is best scored on transverse flare or T2 weighted images, where a score of 0 to 1 is given to white matter hyperintense lesions. So a score of 0 means that either there is none or just a single punctate white matter hyperintense lesion. Multiple, a score of 1, multiple punctate lesions. A score of 2 is there's now beginning of confluence of these lesions, which is also seen as bridging. Then a score of 3 are large confluent lesions. So these are a series of axial flare magnetic resonance images that are taken at the level of the lateral ventricle. Now, the series of images labeled fascicles 1 just tells you that there are multiple punctate periventricular and deep white matter hyperintense lesions seen in the brain. Fascicles 2 just tells you that there's an attempt at bridging of this or coalescing of these hyperintense lesions, periventricular and deep white matter. So you can appreciate these coalescing hyperintensities. And you can also notice caps of periventricular flare hyperintensities, which are also in keeping with chronic small vessel disease. Now, fascicle 3 just shows you large confluence lesions that are seen bilaterally. The Kodam score, in addition to the MTA score, parietal atrophy has also been found to have a positive predictive value in the diagnosis of Alzheimer's disease. So there's characteristic atrophy of the precuneus, and it's also seen that young patients who may have Alzheimer's and have a normal MTA score. So if you use Kodam score for these patients, we're able to actually see out those that will, well, those that have amnestic mild cognitive impairment that will convert to Alzheimer's disease. So the Kodam scale rates parietal atrophy based on sagittal T1, axial T1, and coronal flare images. Now, the idea is that the posterior cingulate and the parieto-occipital sulcus are rated in this Kodam score for parietal atrophy. Now, a grade of 0, there's basically no cortical atrophy, or the sulci as seen on the image are closed. So both for the parietal lobe and the cuneus are closed. Grade 1 is mild parietal cortical atrophy. Grade 2, substantial parietal atrophy. Grade 3 is an end-stage knife blade atrophy that is seen as extreme widening of the posterior cingulate and parieto-occipital sulci. Now, the top images here are sagittal T1, axial flare, and coronal T1 images in that order. So a score of 0 for Kodam based on parietal atrophy, as we have seen, that there's really no atrophy that can be seen. Now, the idea of this Kodam is that it is the highest score for each of these images that is given as the overall score for the Kodam in any plane. So if you're taking sagittal and you see a Kodam of 2, it is the highest level for, and the highest level for the Kodam score or atrophy is 2. That is the score for that particular image. So if you don't go and say there's 0 for sagittal, 1 for axial, and 2 for coronal. If it is coronal that we are saying Kodam score of 2, then we are going to assign it that score. So basically, the images labeled as 0 are just telling us that there is no cortical atrophy. So the sulci are closed. So both the parietal lobe, the cuneus, the precuneus rather, and the cuneus, as well as the parieto-occipital sulcus appears okay. There's no atrophy or there's no widening of that sulci. Now, when we get to Kodam 1, we start appreciating widening of the sulcus, the parietal sulcus, widening of the sulci within the parietal lobe, and this visual rating is 1. We give it a score of 1. Now, for Kodam 2, we can appreciate some widening of the sulci in the parietal region, or parietal occipital region rather, and there's some widening of the parietal occipital sulcus. Now, for the axial flare, you can appreciate these tiny hyper-intense cortical white matter lesions, which we would say this patient has a Fazekas score of 1. Since they are punctate, they are small and are seen in the cortices. Now, for coronal T1, we can appreciate this extensive or substantial parietal lobe atrophy. Now, it's interesting to say that the medial temporal lobe may be normal in these patients, but because of this score, we're able to also know patients that can convert to Alzheimer's disease, which is primarily in the hippocampus. Now, a Kodam score of 3 just shows you widening on sagittal view, just shows you widening of the parietal sulcus, as well as this knife blade atrophy that is seen in the coronal, best seen on the coronal. Knife blade configuration is best seen on the coronal T1. Now, MRI assessment in dementia. For global atrophy, we try to rule out dementia, vascular dementia, or normal aging. For MTA scale, or MTA scale rather, we would want to rule out Alzheimer's or frontotemporal lobar dementia. For frontal atrophy, frontotemporal dementia, parietal atrophy, using the Kodam score, Alzheimer's disease, white matter lesions, Fazekas scale, used to rule out vascular dementia or normal aging that can occur, chronic small vessel diseases that can occur in normal aging. Then strategic impact for vascular dementia. Now, Alzheimer's disease is the most common cause of dementia, accounting for about 60 to 75% of dementia cases. Now, there is a progressive decline in episodic memory, language, visuospatial, and finally executive function. And as we said, that dementia should be severe enough to interfere with patient independent daily living. Hello? Okay. So pathologically, Alzheimer's disease is characterized by extracellular senile plaques, that's amyloid beta 42 proteins. So extracellular accumulation of amyloid beta and intracellular tau protein formation, which are connoted as neurofibrillary tangles, NFTs. So when these proteins are accumulated in the brain, they give a pathologic diagnosis of Alzheimer's disease. Now, NFTs usually, sorry, can you mute your mic? Sorry. So NFTs are usually seen, or well, are usually accumulated first in the entorhinal cortex before they proceed to the medial temporal lobe and the neocortical areas. And they are seen in greater than 65, Alzheimer's is seen in greater than 65 years, about 10%, and above 80 years, about 40% of dementia cases. Now, the risk factors for Alzheimer's disease includes the apolipoprotein E4 allele. So studies have shown that if a patient should inherit one of the alleles, it increases the risk of having Alzheimer's disease by three times. And if the person inherits both alleles, it increases the chances of getting Alzheimer's by eight times. Now, physical inactivity, hypertension, and a family history of Alzheimer's disease are risk factors. While formal education, so the higher someone gets, the higher someone gets academically, the lesser the chances of having Alzheimer's disease, according to studies. Then Mediterranean diet, which is basically plant-based diet, and diet that are well low in fish, red meat, also have protective effects. Then high income earners too, because really they have a lot of thinking to do before they earn so high. And social network and family support are protective factors. So Alzheimer's disease can be classified based on the clinical pathologic correlates, into definitive. So definitive just means that you have a clinical diagnosis and a histopathologic diagnosis as well. Probable just means that there is clinical and no histologic diagnosis. Then possible means that we are seeing clinical symptoms, but they are neither here nor there. Now, this is a coronal magnetic resonance image, T1 weighted image of the brain. We can appreciate the reduction or the marked reduction in the size of the hippocampus here bilaterally. So this is the portion of the hippocampus. Then we should also notice that the entorhinal cortex is also reduced in this image. So we can give a score of MTA3 for this, MTA2 for this patient, and an ERICA 2, because on the contralateral aspect, this collateral sulcus is also widened, which is giving us, which will give the patient a score of 1, ERICA 1, for this image. So this is a patient that has Alzheimer's disease. Now, CT2 is also employed in the evaluation of dementia. Well, basically, in the absence of MRI in low-income countries like Nigeria, where we have paucity of centers with MRI, CT can come in handy, where it will just show, this is a cone down coronal reformatted CT image of the brain at the level of the lateral ventricle. Now we can appreciate there's marked hippocampal atrophy bilaterally seen here. So it's most likely that the hippocampus, in some author's description, the hippocampus is sleeping. So then you can also appreciate widening of the lateral ventricles, which is in keeping with vasodilation of the lateral ventricles. Now, SPECT and SPECT imaging, which is a perfusion imaging, just tells us about the perfusion of the brain, basically. And this is done using radio tracers. So a radio tracer is injected into a patient, and the patient is given some time for circulation of the radio tracer. And now these radio tracers usually emit gamma rays. So the patient is injected with this agent, and after a while, say 30 minutes to 1 hour, they are placed under the gamma scanner that would now pick up emitting gamma rays from these metabolites. Now, it is noticed, or it is noted, that in SPECT imaging, the areas of the brain that are perfused are basically going to show increased color flow. So the color flow typified by orange or red here is just signifies that there is perfusion to these areas of the brain. Now, the parietotemporal regions bilaterally don't show color perfusion, or don't show color as it were, which is in keeping with a biparietotemporal cortical perfusion. Now, if you combine SPECT with a CT, which is SPECT CT, it just tells you that you can localize function and anatomical against anatomical structure. So this we may not be able to know. We just know that, okay, it's around the parietal, the posterior parietal region, as well as the temporal region. But here it gives us the plain anatomy. You know the gyro that is involved in the hypoperfusion. For PET imaging, uses a glucose analog, which the brain usually uses glucose for metabolism. So what this imaging basically does is just to create a lookalike like glucose that will be injected into a patient. So 8-fluorodeoxyglucose is injected into a patient, and after a while there is activity, there's metabolism going on in the brain. So this series of images are PET images. The first image here is a normal axial image where you can see this color coding as red that signifies metabolism. So it is seen the cortices rather have metabolism in them. So this is a normal axial and a coronal image. Just tells you that there is metabolism going on. Now, for the images under here, you see that there's reduced activity within there's bitemporal reduced activity or metabolism in this image. On the coronal too as well, you can appreciate that the parietal lobes have reduced metabolism, which is consistent with an advancing disease, advancing Alzheimer's disease. Now, amyloid PET just tries to show that now because beta amyloids are build up in the brain, the beta amyloid proteins build up in the brain. So you're going to insect a radio tracer that will just go to bind to these misfolded proteins within the brain. So amyloid PET just tries to say, okay, you inject a patient with radio tracer and it will bind to all the areas that have increased accumulation of beta amyloid. So on this image, the red on this image just shows you that there is binding of this amyloid radio tracer to the amyloid protein in the brain. So it's preferentially seen in the prefrontal cortex, the precuneus, and the posterior cingulate regions of the brain. So amyloid deposition is more seen in the prefrontal cortex, precuneus, and posterior cingulate gyrus. Now, this is a SPECT image. It's courtesy of the Nuclear Medicine Department, University College Hospital, Ibadan. Now, this was a novel case that was done last month. If you notice, to the images on my right here, these are just series of SPECT. These are SPECT images that tell us about perfusion. They tell us about perfusion. So areas in the brain where there are perfusion, it will light up as yellow or red. But areas that have that are hypoperfused they will have paucity of these color coding. So basically, in this image here of the patient that was seen in UCH, we can appreciate paucity of color coding in the posterior parieto-occipital and the parieto-temporal region. So this area on this sagittal image, you see paucity of color coding in this parieto-temporal or parieto-occipital region. Now, in the image, in the inferior image or the lower image here, you can appreciate some subtle frontal hypoperfusion bilaterally, but it's to a lesser degree rather, than what is seen in the posterior parieto-temporal regions posteriorly. Now, this just tells you an idea of perfusion. Now, Neurostat 3D surface stereotactic map is basically a compendium of a compendium or a database of normals. Now, this particular 3D SSP statistical map is basically, it's a novel one because I think it's one of the newest one that is being used in this part of the country. It just connotes that normal brains have been imputed on this database. Now, across 20 years and across 40 countries, they've been able to generate a database of normal brains. Now, the map here can either be an increases map or a decreases map. So it's not just telling you about perfusion, it's just to give you, to confirm what you have seen on your perfusion study. So perfusion studies, we have seen that there is a paucity or hypoperfusion of certain areas of the brain. But this 3D statistical map just increases your confidence that, okay, what you saw, it's actually there or it's not there. Now, you will see this area with DEC here, it just shows that it's a decreases image. So we are using this to map on our SPECT images any area of the brain where there is a decrease in perfusion will will be seen as this color coding here. So if the area is dark on this image, it shows that there is perfusion going on there. So areas that are not perfused on this decreases image just shows that the area will light up. So an area that is having hypoperfusion or hypometabolism will light up on this statistical map. So you are able to appreciate on this right medial, just because of time, this right medial and left medial areas of the brain, it just tells you that there is hypoperfusion of the posterior cingulate gyrus and the precuneus, which is in keeping with a patient that has Alzheimer's disease. So it just strengthens your confidence in the hypoperfusion studies that we've carried out. Dementia with Lewy bodies is actually seen a side nucleopathy that is related to Parkinson's disease. So there's a triad of cognitive impairment, visual hallucinations, and Parkinson's symptoms. Now, the idea is that Parkinson's symptoms would, like the resting tremors and the bradykinesias, will occur first of all. Now, it is important to monitor this patient for 1 year. If in less than 12 months, there's onset of cognitive impairment on the background of dementia, you can make a diagnosis of dementia with Lewy bodies. Now, it's also important to note that occipital lobe involvement differentiates dementia with Lewy bodies from Alzheimer's disease. Now, this is a cone down FLAIR image. These are cone down FLAIR images of the midbrain. Now, if you can appreciate on this image, the substantia nigra is a nuclei, so it has a lot of cell bodies within it. It's hypo intense on FLAIR images. Now, if you trace the posterior limb of the substantia nigra, you notice that there is one limb here, a hypo intense limb here, and another here. Now, in between these two limbs of the substantia nigra is what they call the nigosome 1. Now, some authorities have said that in a normal patient, there is hyperintensity of this nigosome in a normal patient. Now, when there is absence of this nigosome in a FLAIR image for a patient that is suspected of having dementia, which in this image here, we cannot see any comma-shaped hyperintensity on this posterior aspect of the substantia nigra. It just tells us that there is absence of the swallow's tail sign, which is seen normally in a normal, healthy, non-cognitive impaired patient. So this area just tells you that, okay, this is the one limb of the swallow, which is seen here. This is one limb, another limb. Then in between it is the nigosome 1. So absence of this swallow tail sign is raising the suspicion of dementia with Lewy bodies on the background of Parkinson's symptoms and cognitive decline. So this is a PET image, 18 fluorodeoxyglucose image. Oh, sorry, please, and mute your mic. Now, a fluorodeoxyglucose PET image that just shows us that there is hypometabolism of the posterior of the occipital region in this area, but there is sparing of the posterior cingulate cortex. So bilaterally here, you can see that the color coding that is seen in the frontal and the frontal region is not seen in the parietal and occipital region. However, in the cingulate cortex, there is preservation of perfusion or metabolism in that area, which is in keeping with the cingulate island sign. Once you see it, you can increase your diagnostic yield of dementia with Lewy bodies. Now, frontotemporal dementias are basically frontal and temporal lobe atrophy, and there are different types. The behavioral type deals with the personality, the semantic, the progressive non-fluent aphasia, and the fluent primary aphasia. There are all types of frontotemporal dementia. Now, these are series of coronal T1 weighted MRI images, And the second image is an axial flare image of the brain. Now we can appreciate this increase or widening of the sulci of the frontal lobe, as well as the temporal lobe in this flare image. Now, worthy of note is that the hippocampus can be normal in size. It may be normal in size. So it's not just looking at the hippocampus that would give it away. You also have to look at the frontal and temporal degeneration of neurons. Now, for this flare image, if you can appreciate this slightly hyper intense area, which is in the region of the head of the caudate nucleus. It is seen on the left here. However, there is little or nothing seen in the on the right here. This also increases the diagnostic yield for a frontotemporal lobar degeneration. So when you see frontal and temporal atrophy, please look at the head of the caudate nucleus as well. So this is an axial flare image of the brain taken at the level of the orbit. We can appreciate asymmetric temporal atrophy. Now there is reduction in the neurons in the left temporal region compared to the right, and giving this knife blade atrophy. So it looks like a knife. It's thin, paper thin, looks like a knife. Now there is bilateral hyperintensity of the remaining medial temporal lobe, which is suggestive of gliosis, but more on the left. So PET images, fluorodeoxyglucose PET images and flare correlation just tries to give us a map between normal Alzheimer's and frontotemporal dementia. So on the normal PET scan, you can appreciate metabolism. There's increased metabolism, which just tells you that, okay, this person is a normal patient. And if you compare it with the flare correlate, now, even if there are some minor punctate white matter hyperintensities in the deep white matter in the central semi-ovale rather, you will not be able to appreciate it on the PET. So it just tells us about perfusion. And comparing normal with Alzheimer's and frontotemporal, for the Alzheimer's, there is hypometabolism in the temporal lobes, the posterior parietal and temporal lobes in Alzheimer's, which is typified here, is sparsity of this red color seen bilaterally, while in the frontotemporal dementia, the sparsity of metabolism in the frontal region, as well as in the temporal region on the right. There's also compensatory exvasodilatation of the lateral ventricles in the flare image. Vascular dementia is second to Alzheimer's disease, and vascular risk factors such as hypertension, diabetes mellitus, and stroke also qualifies a patient to have vascular dementia on the background of reduced cognitive, reduced cognition. So large and small vessel disease of the gray and white matter, and essentially subcortical U fibers are spared. Now, large vessel strategic infarct, which connotes neurons that are responsible for behavioral patterns and cognition that are seen in the thalamus, the basal ganglia, and the angular gyrus especially. So when there are infarcts in these areas, they point towards a vascular cognitive, vascular cause of cognitive impairment. And it is also seen that in vascular dementia is a stepwise impairment of cognition. So the National Institute of Neurological Disorders and Stroke criteria in diagnosing, radiologically diagnosing vascular dementia divides this into two: one, the topography and the severity. Now, for the topography, where is involved? The large vessel affectation will be seen in the MCA territory or MCA association factors, association areas via the parietotemporal and the temporooccipital areas. Then for ACA, if ACA has to be involved in this criteria, it must be bilateral ACA affectation. Then a PCA or a PCA affectation for large vessel should be seen in the paramedian thalamus and inferior medial temporal infarct. While watershed territories that are between ACA and MCA and between MCA and PCA have to be involved. Now, small vessel lacuna infarct, at least it is stated that at least greater than 2 lacunas infarct should be seen in the basal ganglia, the frontal cortex, and periventricular or bilateral thalamic areas. Now, based on severity, the large vessel lesion should be seen in the dominant hemisphere. Then there are bilateral large vessel strokes that should also be seen in those patients. Now, leukoencephalopathy, which is just white matter changes, should be greater than 25% of the total white matter area. Now, these are a series of flare. The first image here is a flare image. Second is flare axial flare, axial T2, the second image, and the one under is a coronal T2 weighted image. Now we can appreciate this large confluent lesion that are periventricular and deep white matter, which is in keeping with the Fazeca 3 lesion. It is also noted in the T2 weighted axial image where you see periventricular large confluent lesions. Now, worthy of note is that the hippocampus rather, may be normal. So the hippocampus is this area here, seen in the medial temporal lobe, bilaterally. It may be normal for a patient that has vascular dementia. So MRI findings in dementia, in hippocampal atrophy is seen more in Alzheimer's, temporal and frontal atrophy is seen in frontotemporal lobar degeneration, parietal atrophy is seen in Alzheimer's using the CODAM score. The lacuna infarct are seen more in vascular, white matter lesions, and strategic infarct as well. Now, what do you expect to see in a radiological report for a patient you have sent to the radiologist or the neuroradiologist for dementia assessment? Now, are there classical findings in dementia syndrome? It should be written there. It should be included in your report. Are there alternative causes of neurocognitive degeneration, such as an anterior cranial fossa meningioma or a subdural hematoma? The hippocampus, is there signal intensity on T2 that you want to implicate ischemia, or on a T1 weighted image, are there atrophy noted in the hippocampus? Now, a DWI image or a DWI and its ADC map should be used to rule out acute ischemia, and you can also use it to rule out a Creutzfeldt-Jacobs disease, which are seen as some punctiform, some gyriform areas of restriction in the cortex. T2 hyperintensities. Are there T2 hyperintensities in the periaqueductal gray matter or mammillary bodies that could signal an alcoholic encephalopathy, which is also a cause of dementia? Now, the scoring systems, the MTA, the ERICA, the CODAM, have to be included rather in your report as a radiologist that is trying to rule out or ruling a dementia subtype. Then microbleeds, based on the number and the location, is this strict global distribution, or are there more than 2 in the cortex or deep brain regions like the thalamus, to try and rule out a cerebral amyloid angiopathy or a hypertensive atherosclerotic vasculopathy? Now, you also use the NINS iron criteria to rule out vascular dementia. Now, the challenges are enormous, really, in the dementia management. Now, the first is cost and accessibility, because you ask yourself, how many patients can afford this? These are expensive machines. How many patients can afford this? Complex interpretation, you will need expertise, specialized expertise, to be able to interpret this image based on your clinical history. Radiation exposure, patients are going to be exposed to radiation. They have to do a SPECT or CT. Now, false positives, because imaging results can show amyloid or tau deposition without clinical symptoms. So does it mean that we want to give this patient, tag the patient, Alzheimer's disease? Now, for false negative, early stage or atypical presentations of dementia may not show any clear imaging abnormality, but the patient is having a cognition decline in 2 cognitive domains. So those are the challenges that are encountered in dementia imaging. Now, there's lack of standardized protocol. The protocol we just gave is something that is a protocol that I had to look at different training centers and their protocol with their machine as well, and what the prevalence is for dementia in that location. So there's lack of standardized protocol, which I mean, we should research would help us to develop a standardized protocol. Then invasiveness, patient tolerance, ethical and physiological and psychological concerns, then integration with clinical data. So it's one thing to do research, another thing to include it in clinical management. So you do research, wonderful research, and it's not being seen for people to try out in clinical practice, then there's no essence of this research. Then translation of clinical practice to of this research to clinical practice. Now, in conclusion, neuroimaging plays a vital role in acute diagnosis and subtyping of dementia. Structural and functional changes in the brain via patterns of atrophy, mineral deposition, and cerebrovascular damage can assist in clinical decision making. Research will continue to unravel the mystery of this disease entity called dementia. These are my references, and thank you for your audience.